Did you know that joint replacement surgery has been on the rise in recent years? Now, about 773,000 Americans will have a hip or knee replaced each year.
And to what do we attribute this? Our joint replacement experts will tell you on this week's Health Talk.
We are up next. I'm Dr. Vicki Smetak.
And I'm Dr. Eric Mazer. Today we're going to discuss joint replacement surgery. Our first guests are Dr. Michael Lynch. He is the co-director of the Comprehensive Joint Replacement Center at Norwalk Hospital, and his satisfied patient, at least I hope satisfied, Richard Nicholson. Welcome to Health Talk.
Thank you. Thanks for having us.
Welcome. So, Richard, you are a recipient of a new joint from this gentleman right here. Is that correct?
I feel much better for it as well.
Glad to hear that, sir. What were some of your symptoms leading up to the surgery?
I think the main symptom was it was getting weaker, and no matter how I laid my leg, it was still pained. You know, I could have it up, I could have it down, I could sit for an hour. It was just very painful.
And this had been going on for a long time, or a few months?
No, about 4 or 5 years,
Wow.
I would say. It started that way anyway.
Was this a typical story for someone, just progressive pain?
Yeah, Richard was with me for quite some time, and we used some conservative measures to manage his pain for a while through medications and injections. And we talked. His X-rays look bad, but it's really up to the patient to decide when they've had enough. And he finally had enough.
I had enough. I said, "Time. This is the time."
That's right.
This was wear and tear arthritis, from what I understand, the osteoarthritis. Is that the most common thing that you see?
Yeah, by far and away. There's a lot of other arthritides or forms of arthritis that are inflammatory, but the wear and tear is what we see the most of.
And I guess the problem with that is that once it's worn down, once the cartilage wears down, there's not a lot you can do to repair it short of replacing the joint.
Yeah, we haven't gotten there yet. That's the next Nobel Prize, when somebody can paint a biologic surface. We've made some advances in some of the biological reconstruction, but not when it's reached that stage that Richard got to.
That's true.
So, Richard, were you fairly active before the pain really
Yes,
started
I was.
to become
a lot of walking. I did a lot of walking.
But after a certain point of time...
Well, I still walked, but it wasn't quite the same.
But not quite.
I suffered more, right? It was like going off a curb. I had to think twice about it, you know.
What made you finally decide? What was that trigger that made you...
I couldn't tell if I was either too young or too old. Dr. Lynch told me I was too old, so no, I went ahead and did it anyway. No, it was time, because I'd gone through the shots and all that, so it was time.
Yeah, but that's a good point. Are there age criteria these days with joint replacement being what it is?
To answer that question, I like to think more of physiologic age, not chronologic age. So,
that's a good point.
Richard,
that's what I like to think.
That's it. We all tend to get there.
That's true.
It's much more comforting to think that I'm 40.
Right.
So Richard had a mismatch there. He was quite physiologically younger than the number said on paper, and so you tend to edge more in that direction. It has to do with other health concerns more than anything else. And with some of the newer technologies, where it used to be you waited till 60 or 65, it was an absolute. I just did recently a 49-year-old. It's not a good idea because they have a limited lifespan, but when the knee gets to a point where nothing else works, it's good to know there's technology that'll support that.
Sure.
And maybe you could show us a little bit about the knee, Michael, because I know you brought some models, and tell us what's going wrong when people have
a knee
this
with
problem.
me.
The knee's a fancy mechanism. There's two types of cartilage in it. The cartilage that lines the joint, painted on the surface like the coating on a ski, and it's on the other lower side too. And then there's these meniscus pads. When somebody tore a cartilage, it's these pads. And either from a torn cartilage, from genetics, from old trauma, or just from aging, this stuff wears out, and you get to be where it's bone on bone. And the point I like to make is a lot of people have this idea that, well, when this knee doesn't work, we go in and cut the bone here, take it out, and insert some kind of mechanical device. But it's really a resurfacing procedure, kind of like changing a tire. So we shape the ends of the bone to accommodate, so it's peeled off, shaped off that way. Most of the bone stays intact, and this new shell goes on top to coat it. And the same thing happens on the tibia side. And because people, like I think Richard, got quite bow-legged by the time we were done, we're able to restore that alignment by how we make these cuts. So in a nutshell, that's a knee replacement.
What can a patient expect then after an operation like this, as far as return to what level of mobility and how quickly?
They are pretty gimpy for about a week, and but they get up and walk the night of surgery, if not the next morning.
We actually have a video clip of some patients who are recently operated upon. I'm sort of amazed to see how well they move around. The thinking about this has really changed, hasn't it?
Yeah, when I was a resident, it was 4 weeks in the hospital after a joint replacement, and now they're home in 2 or 3 days. And by home, I mean home. We used to send a lot of people to rehab, but you went right home.
Right home.
Well, yeah, let's bring up the video clip so we can see that. So how quickly did you get up, Richard?
I was up the next day after the operation, but then I went right home, and I had no problem.
So here we have, this is a new joint replacement center at Norwalk Hospital, where a lot of the modern techniques, all the modern techniques have been implemented. Can you say a little bit about what we're seeing here, Michael? Obviously a shower.
There's no one in it.
Private bath, private rooms. We certainly have tried to make it look nice, but it's functional. And right across the hall, this gentleman who's had a recent hip replacement the day before.
Yeah, we have to emphasize, this is the day before he had this is the day after he had the surgery.
That's correct. And
he's walking stairs.
People ask, how do I go home? I've got a lot of stairs. Well, we check that out through this technique, and with the rehab right there, we practice getting in and out of bed, of their bed, and the one in the workout room here. So everybody on the floor is focused for early mobility. We're encouraging people to get up. We have these group exercise sessions so that we work together. Did you find that useful, Richard?
Very useful.
They're competitive too, wasn't it?
I know.
I was just going to ask if there's peer pressure to out-compete.
No, they were very good.
Yeah.
But it's important to keep that up.
This is practice getting in and out of bed. That's what originally I thought that was a writing crop to move the patients along, but it's actually a mechanism to help them get into bed.
But this is pretty typical, right? The next day following the surgery, this is not a superstar patient, for example. This is the expectation.
This is pretty typical, middle of the bell curve. There's always variations.
Right.
And I think it's important to see that they're all wearing normal clothes. We don't have that open flap Johnny in the back.
Right.
So
I'm
that.
sure the patients appreciate.
Yeah, they do. We try to treat them as if they're well, and it works.
And you've also used some new post-operative pain regimens that have been very successful, haven't you?
Yeah, that's correct. A few years ago, we gave them IV narcotic where they'd push a button, and boy, it took care of their pain, but we couldn't move them for 2 days. They were stoned. So we use these other oral pain medicines supplemented with some anti-inflammatories, local anesthesia at the site, and that's what allows us to get them moving quickly.
Richard,
I had no pain. I don't recall any pain.
Really?
I really was very well done.
It's a big operation.
Very well done, yeah.
That's a little outside the bell curve, but that's all right.
Well,
So Richard,
probably didn't even realize it. That's why.
But maybe that's a good point to wrap this up. Here we have a patient who had a joint replacement that was painless.
Right.
So
Basically, yes.
That's the best advertisement for Dr. Lynch we could possibly hope for.
And the food was good, too. They were excellent food at the hospital.
Well, can't ask for anything more than that.
No, you can't.
Thank you both very much.
Thank you.
We'll be back after this short break to talk more about joint replacement and some of the modern techniques. Hi, we're back with Dr. Nicholas Polifroni. He's co-director of the Comprehensive Joint Replacement Center at Norwalk Hospital, and Terry Bagnulo, one of his satisfied patients.
Welcome, Terry, Nicholas. Thank you for coming.
Thank you.
Terry, tell us your story. You had a hip replacement, is that right?
I had a hip replacement because over a couple of years' time, the pain in that hip had become progressively worse, and it was really keeping me from doing all the things that I was used to doing, all the things I wanted to do, and interfering with my life.
That must have been really frustrating.
It was.
And you reached a point where you said,
I was at the point where something had to be done, and I knew something could be done, so I was very happy to make the arrangements, meet Dr. Polifroni, and come into the program.
So, Nick, I asked this about our first patient. Is this a typical story for a hip replacement?
Yes, it is. Many patients put up with pain for a long period of time. We actually want them to try to put up with it for a period of time to make sure that they are not in some type of temporary circumstances and that they actually are at a point where they're ready to make the step into a surgical procedure.
Let me ask you, you look fit. Richard, before you looked quite fit. Does it help to have patients who are otherwise fit going into these operations in terms of their rehabilitation and success?
Absolutely. I tell all my patients it takes two to tango.
Right.
You know, we do our job. There's a great program at the hospital, but if the patient is prepared and motivated and ready to take on the challenge of rehabbing from the joint replacement, like Terry did so well, the results are far better.
The recovery is much faster.
Much faster.
Right.
Yes.
Terry, well, I want to talk about the surgery in a minute, but how has having the successful hip replacement changed your life?
Oh, I'm back to what I want to do.
What kinds of things?
Yes, all kinds of things. Well, one of the things that I had been doing for years was walking. I'm a beach walker early in the morning, and I've been doing that for years, and I simply wasn't able to walk anymore. The pain was such, the pain would shoot through my hip and through my leg, and I wasn't able to do that. So I'm back to doing that, except this morning.
Too hot.
Too hot.
Too hot for this.
But I have that mobility again. I can do that. I was at the point, too, of thinking, if I go someplace, how far will I have to walk once I get there? And, of course, that's not a problem anymore.
No, not if you're always thinking ahead. I mean, that's a real impediment, trying to gauge how long you're going to be until you get
and
tired.
that's one of the things we use is we ask them, what about your quality of life? People ask, when do you have a joint replacement? It's a hard question. We try to simplify it and say it's all about your quality of life. Everybody has a different standard for their quality of life. For some people it's walking to the mailbox. For some people it's taking a 5-mile walk.
So we saw a video clip in the earlier segment of a patient who had had a hip replacement who was up and out of bed the very next day. Was that your experience as well?
Absolutely. Up the very next day, up walking in the hospital with a physical therapist.
And your pain level? Well controlled?
Was almost nothing.
That seems really almost inconceivable to me, and maybe to our viewers at home, because it seems these are big operations. They're removing pieces of bone. Bone tends to be, all of us have had fractures, know that bones hurt. And they go, why are we, and this is different than in the past, why, it really has changed, and maybe you can speak about that, because I know you've adapted some national findings to our use here at Norwalk, and they've really worked.
We've implemented a multimodal pain management program. That's basically what we've done. We really treat pain preemptively, so patients are actually given medication before they have surgery. Intraoperatively, they're given medications that last throughout the rest of the first day. And postoperatively, we've eliminated intravenous drugs, which really sort of just narcotize the patients and make them lethargic, and give them a lot of different medications that work on different nerve pathways and pain pathways to make it an incredible experience. And they're just drugs we've all used before, but we're using them now in conjunction together in a program.
But we really heard 2 patients who said they've had almost no postoperative pain on the show. Is that now rather typical?
It's more typical. I used to make rounds the next day on patients, especially my total knee patients, and I'd stand at the door because I didn't want to walk in the door because they'd be, what did you do to me? This is very uncomfortable. And now it's an absolute pleasure making rounds, because most of them have, even before I get there very early in the morning, they've already been up, they're sitting in a chair, they're looking out the window, having a cup of coffee, and they've already been for a walk.
And isn't the early mobility, or I'm asking this really from a layman's point of view, isn't there some risk in early mobility in moving these joints around before all the tissues have healed?
We used to think so, but that's a myth that we've dispersed. Not just us, it's been happening all over the world, all over the country. It's been dispersed.
Are there any anti-inflammatories administered after the surgery to prevent inflammation later on, almost preemptively, or no?
Yes. We use a long-acting anti-inflammatory Celebrex, one of the drugs, for a short period of time around the operation. We inject Toradol into the wound tissue intraoperatively, and we use Toradol for the first 24 hours, which is a very strong anti-inflammatory.
So you're basically preventing the inflammation that would be leading to this postoperative pain experience that patients used to feel.
Preemptively. So we're not letting it happen. We're not letting the pain get into their brain, into their system before they can experience it.
And as you, Terry, as you got further away from the surgery, how did the pain get worse, or did it stay at that very low level?
It stayed at the very low level. When I left the hospital, I came home, and I had a physical therapist coming every day for 2 weeks. And the instructions were that I should take a Tylenol prior to their coming, half an hour prior to their coming. And I did that, and then I forgot to do it after a while because I really didn't need it. The therapy was done at a level that I could easily work with, and
Yes.
I was surprised myself at how little pain there was.
But she's on the upper, as Dr. Lynch had mentioned, she's on the upper spectrum of the pain level too. Most people still require a regular dosage of pain medication, but we're giving them oral pain medication at lower doses because we're using other drugs.
And I would think also that the early mobilization, getting people walking quickly, results in less muscle atrophy and maybe helps prevent blood clots. Have you seen both of those improve with this aggressive mobilization?
Yes, yes, absolutely.
Now you have a model here. Can you give, for our viewers at home, tell us what a hip replacement entails, if you would?
Okay, the hip socket is basically a ball and socket joint. It has a great deal of range of motion, different from the knee joint, which really only has a small plane of flexion extension. The hip has almost 120 degrees of range of motion. The joint itself wears down. I don't have a normal hip, but the joint itself loses articular cartilage. So what we do is we sneak in through a little incision in the back. We resurface the hip itself, the hip socket, by using fine tools to make it nice and smooth, and then we put a titanium shell up into the socket itself, and then we can place into the shell just about any type of liner we want, and that's the bearing surface that makes the new hip socket. On the femoral side, we remove the diseased ball, that's the most standard type of procedure, and implant a titanium stem that locks down into the femur, which is hollow. And then on top of that we can put any different type of head we like.
Glue that into the bone? Or
no, it's just a press fit, and then there's a hydroxyapatite fretting surface around here which lets the bone grow into it. Same thing with the socket. It's press fit in initially, so it locks into place, but then there's a surface that actually grows into the bone.
And then the bone just goes over it, like
bone goes over it, and we use different size heads depending upon the patient. We use ceramic heads or metal heads, and then this plastic on metal or plastic on ceramic makes the new hip socket.
Is this the same? Is this the joint that Terry has?
This is very similar. She actually had a little bit of a larger head because we were able to use a larger head. So sometimes we use very, very large heads which mimic normal hip range of motion. This is basically what she has in there.
Amazing story. And how do you feel now?
I feel great.
How long before you were able to go back to beach walking?
Oh, really? Just a couple of weeks.
That's really
I have to say part of it. You're going to talk with Courtney, but a great help for that, of course, was the program Courtney does beforehand.
And they're coming up in the next segment. It's a perfect segue for us. We're going to have some of the nurses and physical therapists who were involved in the rehab, which is so important after this operation. So I want to thank you, and we'll be back after this short break.